Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, everybody, and thank you so much for joining us today. Just before we get started, I want to make a quick mention that the Charting Champions program will be turning 3 in October. So we're going to be doing some special events for anyone joining between now and the end of October. We're going to be having a charting event where you will be coming to that class and being able to ask your specific questions on how do I get my charts done after every patient. And you're going to have a good session there with all the types of people who join the program. So it's not just one type of physician, it's anybody working in clinical practice. So that is just a quick shout out. Now, on with the show. So today we have a very special guest and friend. So Dr. Sudha and I have spent many afternoons together with learners in community. So we were part of the Integrated Community Clerkship within the Edson community. Sudha was the peer support and helper for us looking after the students in community. So I'm going to let you introduce yourself and welcome.
Well, thanks, Sarah, my friend Sarah and colleague Sarah. My name's Sudha Koppula. Everyone's welcome to call me Sudha. Sarah, yourself too, of course, like you know. And so I'm an academic family doctor, and I currently am working in Edmonton. I do clinical work, so I have a practice, and that's at an academic center in Edmonton. It's MacEwan University Health Center. Which we're very proud, actually, if I could drop this, Sarah. We're the recipients of the Alberta College of Family Physicians Medical Home Patients Medical Home Award this year. So we're very excited about that. Yeah. And in addition to that, I have administrative duties. I have research activities that I do. And like you mentioned too, I really enjoy my teaching aspect, and it takes me to all parts of the province, including Edson.
Yeah, so much fun. We appreciate you for sure. And so part of what we do here in the podcast is we're looking at how to create sustainable clinical medicine. And part of that, a lot of the questions I get are from the preceptors or the physicians who have learners in their environment. They're trying really hard to work on their own strategies to get home. And then a learner pops in, or a learner is part of their clinical day, or sometimes it's a bit random, sometimes it's scheduled, and then they're like, now what about having learners in this environment? But before we dive into learners, let's hear about you and your journey with medicine. Tell us about you.
Oh, it's been a long journey. This is my 20th year of practice, Sarah. Which
congratulations.
Yeah, thanks. It feels like a milestone, honestly. It feels like this is midway through my career, although I've talked to some colleagues who say maybe it's more than midway, but we'll have to see. I've kind of in my head have planned for a 40-year career, so we'll see how it goes. So 20 years in, I was just reflecting on this earlier today because I had a meeting with somebody who was a preceptor back when I was a resident. And so don't think I really interacted with that person for a while. So when they heard I was in my 20th year of practice, they started doing the math in their head about how old they are, I guess. But I went to medical school and residency at the University of Alberta and graduated in 2004 from family medicine. So that was finishing of my residency and start of practice. And it's been interesting and dynamic. So I started off doing some locums, but there were locums in some of the academic centers. And so that continued an interest that I had developed during residency with teaching and education. So that was really very good. I had an academic interest and I thought I'm going to need some skills for some of the research and teaching work.
Yeah.
Interest is good, but then, there is some of the skill associated. I actually did a master's degree at Western University. And then when I graduated, that was 2009. So Western University is in London, Ontario, and so I was far from home. And I actually got notified of a position at University of Alberta again. And it was one that I was interested in. It had to do with faculty development, which basically just means that ensuring teachers have all the resources that they need to do their teaching, research, and administrative roles really well. And I was interested in during my master's in looking more closely at our family medicine teachers, and so that's what I wanted. It was at home here in Edmonton, and so I said, "Let's do it." I came home, and then my practice has always involved. I had at that point in time involved primary care obstetrics. So it was a great mix of acute and acute care, as well as chronic kind of care as well, having a panel. And the administrative part had to do with running this faculty development program where I've gotten to know teachers from all over our province, really, which has been probably the best part of my job, I would say. Engage in some research activities related to that faculty development interest. And then in terms of the education, I always have had medical students and residents to follow over the course of their programs. So that's what I've started off doing. And there have been some transitions along the way, Sarah. I think one of the things that was a hard thing to do, but okay to do, was to leave the primary care obstetrics part. Part of the reason why I did that, it was after 15 years, I started to have some opportunities in family medicine leadership. One of those had to do with Alberta College of Family Physicians, being on the board there, which is, more enjoyable than some people might think or might perceive initially. It was actually a lot of fun doing meaningful work. But then I became, or was thinking of becoming president at some point in time. And so president-elect is 1 year, president is 2 years, and past presidency is another year. So that's a 4-year commitment. Yeah. And then you had to promise to be at meetings, and you couldn't be tired and say, "Oh, I'll come if I don't have a delivery," this sort of thing. So I ended up making that transition as an example, and leaving that part of my clinical practice to have more leadership involvement. And that's one of the examples of transitions I think that we were talking about earlier. Yep.
Yeah, exactly. So to be able to take on a new role or a new hat, it takes a time commitment for that role, and the ability to say, yes, I desire that, and I know what the time commitment is, and I know what the what's going to interrupt that, and then that priority setting.
Absolutely. And the other aspect of that too, Sarah, is guilt. Do you have guilt? And I mean, I thought about it. This would be a big decision if I left my acute care part of my practice. It's something that I really enjoy. It's exciting and mostly a happy event, especially with obstetrical care. And so I thought, what do I do here? I think that the thing about that guilt aspect is that I was teaching along the way, right? And so part of what I had thought to myself, and I still believe this to be true, is that I contributed for 15 years doing this work myself. But in doing so, being a regular participant in the teaching enabled a lot of our up and coming trainees to do that same work. And so I was able to leave it knowing that I'd left it in good hands without deficit, which I know a lot of us worry about these days, right? And that's part of where I think the teaching makes me feel good, is that when we feel like our time is done, and it's not as though part of it too is that transition. No one asked me to leave. I didn't feel like I was no longer, or losing some competency in that practice. It was on my own terms, feeling good about what my contributions were, and said, okay, there's no deficit here that I'm leaving you. Just, welcome these new people into the spot that I had, and I go on to other things. And the thing about family medicine is there's so many things. So for a fulsome, well-rounded career, those transitions are important. And if we can do them without guilt, I think is important. Yeah.
Well, even that guilt is perhaps a normal part of the transition experience. Guilt or even grief of the position that or the identity that we're leaving behind.
It's true. Yeah, it's absolutely true. Yeah. And there's that anticipatory nature of it. You can think about what it might be, because honestly, when that was happening for me, I was thinking to myself, am I going to miss this? How much am I going to say, oh, I don't have this anymore? I mean, I was quite aware of that. And I thought, if it wasn't feeling right, then I would go back to it after some period of time, not necessarily a lengthy period of time, of course, because with obstetrical care, for example, you didn't want to have long gaps in the time that you'd be practicing it. But if that's how I was feeling, if that somehow changed, not living those experiences anymore, then I would make that change back, or do something about it. And knowing that I would be welcome, like knowing that departure from my practice group was really amicable one, and with everyone's understanding. So we could make that transition the other way too, if that's what we wish to do. Yeah.
Yeah. Well, what are some of your desires or wishes with regards to thinking about the board and being president of the Alberta College of Family Physicians?
Well, Sarah, I mean, you've been part of this organization too in various roles as well. It's a great organization, and I have to say, one of the best things that I've been involved in so far in my career. It's taught me a lot. Yeah, being on the board is definitely a commitment, just like a lot of different things are. But it provided a great lens on family medicine from a systems level. You could, with your group, and your group being the rest of the board, but also there's the operational committees in that organization. Take a look at how things are designed. I had opportunities there on the board that I don't think I would have had well, I don't know about in any other organization, but up until that point in time, that came up. And so at that point in time, that was my opportunity to learn more about that. And so the lens on family medicine that I had from the systems perspective, like how things are organized, why do we do the things that we do? If there are deficits in one area, well, how are our family area geographically? I mean, how are our family physicians actually coping? How do we support them? So these are things that we know about, but to be able to engage in discussions with colleagues and from all over the province at that provincial level, and to also be enabled to do something about it, to be able to say, well, I have this organization that engages in these conversations, thinks that they're important, looks at many different lenses of family medicine, and can, take some action upon those, is very gratifying, actually, because prior to then, you think about these things and you think, well, there's not much that I can do. But to be involved at that level was very gratifying.
Nice. That's really good. So take us back to you in clinic with your learners, and you're seeing your panel of patients and your obstetric patients, and you've got these levels of learners hanging off you, not necessarily literally. Tell us what it looks like to bring a new learner into your day. How do you kind of set that up?
Yeah. Well, first off, I'm very lucky. I think many of us are when we have a learner start new at our clinic, no matter if they're a medical student or a resident, they do get, like logistical information, where to park. I mean,
Mm-hmm.
what door to come in, who to ask for when you get to reception, that sort of thing. All of those logistical things are managed by a superstar administrator that we have at our clinic, which is great. So when we know we have a learner coming, they get all that information in advance so that their entry and arrival is smooth.
Mm-hmm.
They're spending some time with us. I want to say if it's an elective of 2 weeks or more, somewhere in that time frame anyway, they do get some training on our electronic medical record, partly to facilitate how their workday will go, but partly to introduce them to that feature of care, right? And the different elements of how that is involved in a patient's care. So that's taken care of by another team member. When they do come to work with me in the trenches, usually what we'll end up doing, myself and a learner, no matter again, resident or medical student, I'll first off just figure out what just like you've done today, Sarah, just make sure that I have their name and pronouncing it the way that I should be. That's key for introducing them to patients and to other team members.
Mm-hmm.
And then asking what stage of training they're in. Especially if it's an elective, I want to hear about what made them choose because it's a choice, right? And what made them choose to come. And of course, those are the medical students who are still undifferentiated and could make a choice either towards family medicine or not. So if we can be aware of what some of their thoughts are, that's important. I do go over which stage of training they're in, and then what objectives they have for the time that if they're with me for a long period of time, if they're a resident and I have them for the full 2 years, and we have bigger conversations about like career plans and life goals and locations of practice, this sort of thing. Yeah. If they're around for a short period of time, we might just talk about some of the more, how do we get through a successful day? What are your objectives for the day, right? Often our patient list helps us with that. So we have team members who do a huddle with us at the beginning of the morning session or afternoon session, or we even have evening clinics. So also that, who will go through with us the patients, help us get lab recs organized, can take a look at what screening is due, for example, and give some background on what they've called in for. So we'll go through all of that with our team members. And from that, our learners can figure out what's a valuable visit or who's a patient they would like to see. So I try to remind them that there's the ones that we'd like to see because they're of interest to us, and that's great. There's the ones that are the gaps as well. So which would be valuable because it makes us uncomfortable, and that's okay. In a training role, you get to take your time, you have the support of others. So it's a time to really delve into those things. And even if they make us uncomfortable, go ahead and do it. And that's how we tend to set things up. The other thing is with residents, it's important, especially if they're around for a longer period of time, to have continuity with patients. So we pick out the patients that they have seen before, and our EMR helps us do that too.
Oh, nice. So you've set the EMR up so it can see who's seen them before. Nice.
Yeah, because every time that a learner sees a patient, we have them in a drop-down box so they can actually pick their name and sign up for them. And then what we can do is look back on who is signed up for those patients, and then pick them out, because sometimes we don't have the name recognition, right? And so that's a way to help that out.
Yeah, nice. Okay, so that's a nice systems process to help this learner kind of keep that continuity. What about the expectations with regards to how long are they going to be in the room for? What are they supposed to do while they're in there? When do they come find you? How does that conversation go?
Oh, that's such a good question, isn't it? Yeah. For me, it depends on the level of training of that learner. Honestly, I mean, sometimes we do have shadow students come, like through Alberta College of Family Physicians or otherwise. Sometimes there are students who will say, actually, I did even, Sarah, have it was a pre-med student, like someone who was actually applying for medical school who wanted to shadow. And so, and they were a research summer student at the Department of Family Medicine. And so they asked if they could shadow. So they're even before medical school. So, do you know if sometimes, so there's different levels. If they're really inexperienced, they might actually shadow, like they actually just might come with me, and then we can, have them participate in that. I'll do most of the history. And then I'll say, are there any questions that you also have? And our patients are all very good with, helping them out and this sort of thing. And some joke with them, actually. It's quite fun, actually, if you're a learner. I do warn them. I say, beware of this patient. They'll have a little fun with you. But yeah, if they're a more senior trainee, and there's points in between, but if, say, they're a senior family medicine resident, often one of their goals is to see if they can see the whole patient list themselves with my support, in which case I'll still see my patients. Just it's almost like I've gone over the plan. How are you? How's your family and your cat? And then that's it. It's a little bit more social, especially if those management plans and everything was solidly done by the senior trainee. But there's all the points in between, Sarah. Of course, like you and I, when we've worked together, we know that we've had medical students and residents go into rooms on their own. Quite honestly, the way that my clinic is set up, I have 3 rooms to work with in the case that I have a learner who is in a room and wants to spend some extra time because they're learning about that patient or really trying to understand what the concerns are. I don't worry too much about time because I have 2 other rooms to work with. It's different if you do have that space crunch, though, definitely. But if I get that spidey sense that, boy, I haven't seen that learner in quite a while, I might just knock on the door and poke my head in and just ask if they need anything, like not as a time check or pointing at my watch or anything, but just say, is there anything you need? Would you like me to drop in? And go from there. I really, quite honestly, I know learners worry a lot about time. And I tell them generally that's for me to worry about. You go ahead and learn about your patients. The senior medical or family medicine residents are the ones that I will start to get them to think about time. And it has to be, that's part of the sustainability part too for them and their learning as well, isn't it? Yeah. So that's when I start to say, okay, have a look. And there's no harm in driving that interview or session that you have, or that appointment with a patient, driving that along. Like that's an appointment for you to lead. So that's okay. Yeah.
When do you fit in direct observation, and what does direct observation look like for a medical student and for a resident, for instance?
Yeah, what a great question. And we've done that together, right, Sarah? That's been really good. So when I'm in communities like Edson or right now my community that I go to with the ICC program is Peace River. And so when I am physically there, what is great is that we make it a bit of an event, right? We make sure that we have some treats around, and it's kind of a fun day. Well, I hope that the learners find it fun. It's kind of an event, like once every 6 weeks or so, that we have a special day like that. We have the ability for the preceptor. So in the case when we were in Edson together, Sarah, that was yourself. And I'm hoping that that is something that can free you up with if I'm around, because I'll follow the medical students and do some direct observation and so on. I'll when we go into a room, we introduce ourselves, the learner and myself, and then I'll say, the student is your doctor today. My role is the student's teacher, so I'm here to watch them in particular. And they understand that. And I'm really impressed with all of our learners and how comfortable they are with that. And then we conduct the entire appointment and then come and find you, which hopefully you've done all the things that you need to do while we've been doing that together. So that direct observation ends up happening there. In my own clinic, there are two different ways. So one is with me going into a room with my learner at different stages. Sometimes it is at that very beginning stage when you asked Sarah about how we set up the day. We'll pick one observation to do. Either it's a history, so I'll just pop in for the history part, or it's a physical exam component. So we'll say, I know you're here for, a periodic health review, and we were going to do a head to toe type of exam, but I really need help with my knee exam. So Dr. Koppula will come and I'll pop in. I'll do a really detailed knee exam on you, and then she'll pop out. We can do it that way. If there is a conversation happening and I'm physically in a room and I want how that happens with my learner, I'll actually sit beside the patient as much as I can, because then it's harder for them to turn to me and look for my reassurance and so on. They're looking towards the learner. I also try to look towards the learner for if there's questions that the patient is asking. If they're looking at me, I'll look at the learner, and so then trying to encourage that interaction between the learner and the patient. One other thing is with my clinic, what's really very fortunate is we do have cameras in the rooms. We only ever use them with consent. The patients can tell if they're on or not because of a light and so on. And so I don't have to be in the room to be able to do that. So quite honestly, this being an academic center is one where it's well equipped for learners who've had some difficulty, either in their training, personal life, this sort of thing, where observation needs to be more than just a piece like I'm describing. And so you can watch the entire encounter with a patient's consent and get more information that way without those kind of tricks that you need to almost hide behind a patient to be physically in the room.
Yeah, perfect. What about when the learner is finished with the patient? What is your kind of rules of engagement with regards to finding you? How are they going to tell you the story? How does that work within your flow of your day?
Yeah, I've always said to my patients that if you're concerned about a patient, like physically, medically, you think there's something urgent, please don't wait. I learned this really early in my career because I was a new teacher, and I remember just this one time where it would have been a medical student, I feel, but had actually finished with a patient, but stayed in that room, like stayed in the exam room with the patient, thinking that I would come. Just I would know that when they were done, and they didn't know to come and find me or anything like that. So I did go looking for them, and of course they had finished and were sort of sitting there in silence, I think. I don't know how that worked, but so you're right. First off, any learner will know that if you're at all concerned about how a patient looks, or if they're somehow struggling, or that you think there's something acute happening, and just forget the history, physical part. You just come, and any team member that we have within our clinic will know where I am. So if you don't see me, just ask one of them. They will find me. They know the 1, 2, 3 places I could possibly be at that point in time. I won't be far. So that's one. Second is, when you're done with the encounter, it's almost a script to practice. thanks for, thanks. You end up thanking the patient for working with them today, and you're going to put all of this together, find Dr. Koppula and go over everything. And then both of us will be back to, help wrap things up with their participation. And if they don't see me immediately, they're welcome to ask a team member. Often I'm in another room, or I'm just finding something or talking to another team member, and we'll be back soon. But yeah, they can always ask to find out where I am. No.
Yeah, nice. So your preference would be that the student comes and knocks on your door, or are they going to wait for you to finish with your encounter, then hand over? What do you think?
It's urgent. Yeah, if it's urgent, knock on my door.
And otherwise they're going to wait?
Yeah, otherwise they'll wait for me. I can now, so this is part of the faculty development part. As a teacher, we have a sense of time, the spidey sense of time. And so I'll be able to, it's partly spidey sense of time, but it's also the fact that I've known my patients for a lengthy period of time. And so with that, my encounters will be more efficient with patients, because I don't have to go through some of the background that a new learner might have to.
Yeah.
So I'm typically not in a room for a lengthy period of time. And then hopefully that gives the student or resident, if they just wait for me, gives them a bit of time to synthesize the information that they've got, look up whatever they need, find a resource, or figure out the questions that they need to ask me or somebody else. So that period of time I think is valuable, and hopefully not too lengthy for patients to wait around for.
Yeah, we have the like you said before, the teaching how to do things in a timely manner versus the slow immersive learning that our learners need to do as well, and providing them the space to do that slow learning with a patient, not that I don't want you to do 10-minute medicine.
No, and it's
not what you're here to do.
No, exactly. That's so true. And that speed and so on comes from years of knowing a panel, right? And like knowing those patients well and having some lots of practice. And so I will say to learners, I mean, the way to get there is to learn about your patients. And here's your time to be able to do that without having the if you're in a room for a very lengthy period of time and it doesn't feel right, that's okay. You can leave, and this sort of thing. But if you in terms of I need to be done in 10 minutes, take that off your plate. You don't really need to do that. I need to manage time, not you. Yeah.
Yeah, nice. The other thing is that when we're setting up expectations, one of the things I'll say to my students is, if I'm at that point where I need to, move on, I'll just come in and say, hi, you're not in trouble for me arriving to kind of wrap up this session with this patient.
Yeah.
This is just part of the flow of the day.
Exactly.
So
I agree with you. When just last week, actually, I had a situation where there was a learner working with me. And you know how I said at the beginning, we'll pick the patients that are most interesting. Well, they chose this one patient who they were taking a fair amount of time with, but rightfully so. There were some heavy things going on. So that's okay. But then they had signed up for the next one. So that person had arrived and had been waiting for a period of time. So I did go knock on the door and just ask if they needed anything. And there's just I know the learner had said, well, we're still in the middle of it. And so what I did say is that, okay, I'll go ahead, said a quick hello to the patient, and said that we'll chat in depth a little bit more. And then I did go on to that next patient. But so they didn't get to, the original plan got adapted. I think that's all right. I did go over with that learner who was like that's part of the thing. They sometimes I know that particular learner had said, oh, I'm so sorry I'd taken so long. I said, look, if you were immersed in that patient story and helping them out, you didn't take an inordinate period of time. It's just how we planned our day, and we can change the plan. That's okay. And I told them about the encounter that of that second patient that I had seen. And we had some learning points from that too. So that was okay. We actually even had, so if I had an interesting physical finding or something like that, I would pull that learner out to come see it too. We actually do that in our clinic all the time. Just even yesterday, we had a clinic where none of our residents were there. We just had med students because the residents were all at their academic day. So it's a great day for med students to be there. No residents competing with them at all. So one of my colleagues was looking around the clinic and said, do you have a learner? Do you have a learner? I need to show this learner something.
Yes.
Yeah. So it works that way too, where we say, just a moment, I need to, if okay with you, I'm going to bring one of my medical students in to show them this, if that's all right with you. And patients are always really happy to participate in the teaching part.
Yeah. So much fun. I think that's part of the joy of the day, is when you're like, hey, you're so interesting. Can I go grab a colleague and show them this rash?
Sarah, I had this like years ago. This poor gentleman has now passed away, and he was probably my nicest patient. But he had aortic stenosis that was supposed to be operated on and then delayed some couple of times because he was hemodynamically just fine. It was just that it did need to be done at some point, but he would show up for appointments, and every single time he would have a learner say, I hear you have an interesting heart. And so, and I listened to it. And so there was one time where I didn't have a learner, and he said, I'm always looking forward to a learner listening to my heart and seeing their eyes light up saying, oh my gosh, that's a murmur of aortic stenosis right there. And I didn't have a learner at all. And he sort of left a bit disappointed.
So fun. Okay, one of the questions I get a lot of is how on earth do we handle the teaching and getting our work done? So every encounter with a patient is a learning opportunity for your learner. They've learned something, you've done something in the room that's just blown their mind, or they've seen this for the first time and now they want to know all about it out of your mouth, right?
Yeah, absolutely, for sure. It's quite the challenging balance to strike, isn't it? Right? Yeah. So remember how at the very beginning with the setting expectations, I had said that what we'll do is we'll try to focus on one thing, like one direct observation piece. The same thing goes for one piece of feedback at the end, so that we've done it, it's valuable to them. If they do that regularly, they'll have plenty of data points or feedback points. And it's not overwhelming. So similar thing, what we'll do to keep the flow of the day is and again, it's my job to keep track of time. What we'll end up doing is saying, okay, let's park that for a sec. That's going to be our one in-depth learning point for the end of our session. And let's continue on. And so what we end up doing is keeping the flow of the day, seeing patients, ensuring that they get on their way, and their time is valuable too, of course. We'll stay on time as well. At the end of it, we'll say, how was your morning, or how was your afternoon? And then, so sometimes my learners will say it was busy, I felt overwhelmed. Sometimes my learners will say it was really great, I saw lots of variety. Or someone will say it was a knee day, we saw a lot of knees, there were 3 knees in that afternoon, or something like that. So we'll do a little bit of reflection, and then we'll pick that one thing that we said we were going to park and look at it more in depth. And that's where we can do a little bit of teaching at the time, but then let the patients go, we continue on. And that bit of time also allows for some reflection, like the learners to think about what they had done. If they even say, oh, I should have done this test, we'll say, okay, because what will that have told you? That's different from what we have already done. And it gives us the opportunity then to look up some resources or some, patient decision tools. That'll be helpful for the next time that they see what they just saw. That's how I try to handle it, Sarah. I know
Mhm.
there's different techniques. I just find like keeping the flow of the day to be very important, but to
Mm.
mark that, okay, this is our in-depth thing that we're going to talk about at the end. And it's not a half an hour worth of discussing that topic unprepared. It'll
Mhm.
end up being 5 minutes. Let's review what we did, what kind of resources are there, and pass on some of those tools. No, no.
Beautiful. So it's a contained learning. It can be driven by where would you go to find better information, or here's a little bit more about that we did, but not like this big in-depth spoon feeding there for 3 hours doing a lecture with them.
No, and I wouldn't even like as a teacher, I wouldn't even like this is myself. I don't think I could without like some pre-preparation have all of that ready to go. I
Mm-hmm.
could just say, in a clinical setting,
Mm-hmm.
this is what I saw. A lot of the times when we do something more in depth, I think about like, what are the things that it could be, like differential diagnosis generation, I think is really one of those
Mm-hmm.
key critical thinking moments in an encounter. But yeah, not a lengthy period of time, just enough to effectively manage that clinical situation, which shouldn't take that long to do. Yeah.
Yeah. I've worked with some of the subspecialties where they may have a learner just for the day or for a few
Right.
days. And so, of course, they, being their wonderful selves, want to teach. And that can
Mhm.
be very draining on their time. And so
Mm.
one of the strategies is, what are your questions out of that encounter? And they might have a few questions and you're like, great, just pick one of those questions and you go find the answer for that. And then I can help you understand, did you find the right resource? Did you understand it in the right way? So you're helping them learn and be a better learner, a
Mhm.
better adult learner.
Definitely. And then we're pointing them in the right directions, the right sort of resources. These are reliable ones and
Mm-hmm.
so on. So yeah, that's a good
Yeah.
strategy. Those smart people.
Another thing is if they're going to be seeing the same sort of patient one after the other, you're like, that is a great question. You try to find the answer and watch me do the next one. And you might even see some more about that to help you fill in the gaps
Yeah,
so that
that
it's not taking that spoon feeding, which you really want to do, and you're helping them become a learner and an engaged learner too.
and that is a strategy that I remember using pretty often when I had obstetrical patients and was at my pregnancy clinic because you had the similar clinical
Mm,
presentations
yeah.
at various stages, but that was exactly it. So it was for the next patient, which is the next one up. Give this one a try, or so there's that very focused kind of learning like you're describing. Yeah.
Yeah, so good. I've heard you talk about the wave when it comes to setting up the schedule for your day, because I'll see a lot of the preceptors sitting there waiting to get into the first room because they've sent their learner ahead of them. I'm like, that's just setting yourself up for a very delayed start to your day.
Yeah.
Tell us about the wave from your perspective.
Yeah, it's true. There is there's a resource too that we can or like a handout or something that we can provide, I think, to our audience to about it's just a way to modify your schedule so that you have your learner in certain rooms while you're doing other things and or seeing other patients. And if the wave works the way that it's intended, your volume actually doesn't decrease. It's just basically that you've got it set up in a way such that you can have your learner in a particular room, see a couple of patients, and then review with that one learner's patient, and then go on. But your volume should end up being rather consistent using the wave method of scheduling.
Mhm.
Um, yeah, I know some of our colleagues, Sarah, have tried it. I think it seems to be pretty promising. They find that it works reasonably well.
Yeah,
And like your learner will never see the volume
no.
that's not the idea of it. But they get to take some extra time and really learn from the patients that they do see.
Yeah. Yeah. So if we haven't set it up, or I didn't anticipate a learner today, so I've just got my schedule as is,
Yeah.
I will help set them up saying, okay, you've got this patient coming in 25 minutes. This is something that you might want to learn from them. You're
Mhm.
going to go ahead and file dig or learn about a topic before you see them. I'm going to go in and see the first patient, get kind of the day underway. And as soon as they arrive, they'll go in that room and there you go, you'll go in there.
Exactly. Yeah, they don't have to see the first patient who's on your list. They do not have to.
No.
Because there's plenty of, like you say, background. They can review the chart. They
Mhm.
can think about the presenting concern and think about some questions or an approach, and techniques like that. So yeah, you're absolutely right. Yeah.
Yeah. One of the other things that we look at is come find me when your notes are done, so I can review the note and the story at the same time. And when we're leading that conversation or leading that encounter, we're like, okay, I'm going to be doing my note for a moment and you're just going to stand there. So if you come and
Mm.
talk to him, we'll be like, wait, and I'll keep doing what I'm doing. And then I will take that next patient.
Yeah, absolutely. Yeah, that's a great technique too. I think and I think that techniques like that also help our learners to be part of like they end up being a team member, right? Like I'm
Yeah.
doing this while you're doing this, and we're
Yes.
both doing valuable things. And I hope that sets that tone as well as they go through their day.
So I think what we've heard from you, and we know in the evidence that this is so important, is your learners are welcome. You want them there. You've invited them to come. You've set up your patients to know that this is something that you value as well. And that when you're giving feedback to a learner, it's coming from the place of, I want you to succeed. I delight in having you here. Here's some feedback to help you continue in that journey.
Yeah, and in that way, I feel like we are in a coaching role. So that's I often use the term with my learners. Well, and I'll say that, so especially when it's feedback that perhaps might be challenging to hear, it just to frame it as um, I care about I care about how you're doing,
Mm-hmm.
and how you're developing these skills. And it's because of that I'm giving you a little bit of advice or just asking about your approach here,
Mm-hmm.
and just offering some alternatives of what might work better the next time that we have a patient, or the next time that, say, if they're only around for a short period of time with me, the next time you have a patient, just remember that, give it a try, see if it works. Yeah.
Nice. Yeah. What about you in the room with the preceptors? Because you've done a bit of that peer preceptorship.
Coaching. Yeah.
Yeah.
It's fun too, Sarah. I don't know how you feel about it, but I have to say one of the things that I do is like it's a peer observation, or it's peer coaching really, when um I just come from the lens of a peer. So we
Mm.
never get to see, and in a clinical day, we never get to see each other work. And honestly, there's so many talented family physicians who have different techniques in, physical exam, but also in how they speak to
Mhm.
patients, or how
Mhm.
they speak to their learners. And, it's really interesting to have the opportunity to see. So some of the roles that I've had with faculty development director, or this support role with the ICC program, have been real advantages to me. And I feel really privileged to have those, because I can see some of those techniques that I otherwise wouldn't. It's yeah, it's really very valuable. I mean, whenever I have watched you teach, for example, or any of our preceptors like in Peace River, or my own clinic teach, um, I'll take a look at, like, because I have my own ideas or perceptions of how I would handle
Mhm.
a learner's question or a patient's question and so on. But if I can see a different way to do it, um, then I think I pick up what works well, and perhaps what didn't work well, and so on. But also, like, after 20 years of experience now, can sometimes offer a suggestion. And once again, it's also like, when I hear this from a patient or from a learner, sometimes what I try is this, and the reaction has been, X, Y, or Z, and it just might be something that one of us hadn't thought of before, and that's all it is, because we rarely ever see it happen for each other, right? So it's quite interesting to see a colleague and a peer teach. I pick up lots of great things, and then I might have something to offer too. So it's quite a nice exchange opportunity.
Mm-hmm. Nice. Perfect. All right. Tell us about sabbaticals. Tell me about
yes. So a sabbatical, so I just recently went on a sabbatical. It was for a year's time. So it was July 2022 to the end of June 2023 here. So I've just in the past couple of months returned to practice. That was because I'm employed by the university, it was an official leave where I don't get any of my clinical income, but I do get my academic income to a certain percentage. Mm-hmm. The sabbatical is meant to take off your plate some of the it's meant to take off your plate some of the teaching and clinical, so that you can focus on like the research, which is kind of the academic piece of things. I kept the teaching, Sarah, because I like it. And quite honestly, we were I don't know if we're post-pandemic, but on the fringes of it, or whatever you want to describe it as. And I think some of our programs were lacking in teachers, and I really love it. It's one of the great joys that I have in my work. And so I did keep much of my teaching. And I also had the flexibility to then really do some good work in the research world. I had the benefit of having a locum. So one of the things that is a benefit to teaching is that often when you ask some of your former learners, once they're out and in practice, would you like to do a locum for me? Often they'll feel honored to have been asked. They will say, sure, I'd love to cover your practice. Plus, they'll know your practice really well too. So I had the good fortune of having one of my previous residents cover me. So I didn't have any clinical responsibilities. I did continue to do the teaching with ICC program, which was great. Mm-hmm. And then I focused on my research. So there was a lot of writing. There was some travel, not a ton, but these were things that I could do, especially some of the research and writing that I could do from anywhere. Mm-hmm. So there was flexibility. I know not everybody has the benefit of engaging in a sabbatical, quite honestly, and it does involve an income cut, mm-hmm. no matter in what way you do it. Either if you decide to do it on your own, there's nothing. If you work fee for service, or like myself, none of the clinical income came through during that year. But I did have the academic percentage that came through. So I found it to be a valuable period of time. I had only ever planned to do one sabbatical in my career. I mean, that could change in the future, I don't know. But I wanted it to be mid-career, kind of mm-hmm. where I am now, to take a look at where I've been and where I want my career to go, and hopefully do that with some mentorship, either from peers or those who have been more senior to me and can provide some guidance. So that's what I treated it as. We can make plans all we want, quite honestly. I mean, my sabbatical didn't go exactly the way that I wanted it to. I mean, that being said, it was a valuable period of time that I feel really grateful to have had. And I did come back in July feeling refreshed. Mm-hmm. I remembered all my passwords for our EMR. I don't know how that happened. I did. My first day back was absolutely smooth, and people were welcoming back, including patients, which was lovely. And I said, yeah, it feels like I've never left. It was really smooth. So yeah, and I did feel good. I did feel refreshed. So there's some value in taking, temporary just sort of breaks and coming back to it feeling good. Vacations are good for that too. And yeah, those are good things if we can do them.
What about your junior learners who are now going into practice and they're being asked to take learners? What are some of the things that you hear from them, their anxieties about being in that preceptor role?
Yeah, it happens quickly too, doesn't it? Because there's definitely a need for us as teachers. So, I mean, sometimes, I mean, like I described in the beginning, I did grad school to help me out with some of the skills associated with teaching, but I mean, most of us don't have that. I mean, when I first started teaching, I also didn't have that, right? Until I went and pursued it. But um, I think that it's really worthwhile to engage in some faculty development, or at least contact your faculty development director so that they know that you're there looking for some teaching support, and may reach out, and they'll know your specific circumstance. So that's one thing I think that would be key. But yeah, I think that what happens is when you're new, and even when you're not, you know when a learner's performing well because your day is going well, and you don't feel like a tension really. It's that they're actually helping you as a team member,
Mm-hmm.
and you feel like they're a help during your day. When we have difficulty is when it feels like a strain, and you think that, okay, this day is not going as smoothly as I thought. And so sometimes it's because they're junior, and sometimes it's because there's a problem, right? And both of those situations, I find that when our teachers are new, are a challenge. So what do you do when your learner is very inexperienced? And what do you do when your learner is having difficulty? In the setting that I'm in, and I think the setting that you're in too, Sarah, we've got supportive groups of people who we work with. And we can always ask their advice, or like if we know we're going to work with somebody who's having some difficulty, we can ask in advance, how do I approach my day?
Mm-hmm.
Um, or think about that ourselves if we're a little bit more experienced. But so, for example, the physician who covered me during my sabbatical is in, I want to say, just her second or third year of practice now, and is teaching regularly.
Mm-hmm.
We do frequent check-ins, myself and her, but also her and our clinic director, and who is involved in arranging the teaching and so on. But like a direct contact for that person is the residency or the learners program. So either the residency program or the medical school. If
Yeah.
it's persistent and it's something that we can't resolve at our own site, then we know that we need to ask the program support. We've
Mm-hmm.
done that multiple times, and there's no harm at all in doing that. In fact, they'd much rather hear from us than not, because quite
Mm-hmm.
honestly, I mean, the stakes are high, right? We're talking about patients' health, and we're talking about performance of a healthcare provider. So the programs and the teachers need to know if there's something. So with the new teachers, I always say, look, if something's not feeling right, then you let us know. We'll try to resolve it at our site, and if we can't, then we don't have a high threshold to asking those programs for some support or informing them that something's not right.
Yeah. And giving you a skill set to maybe have an approach with that learner so that they're getting enriched in their environment and you're not feeling like you're taking the burden of all of that training
Yeah, no,
on
and
your own. Mm-hmm.
we're not, I mean, any of the programs that I've ever worked with don't expect our teachers to take on like an undue sort of burden. It shouldn't
Mm-hmm.
feel burdensome. If it's feeling burdensome, then it's worth at least a conversation with the program about why it's feeling like that. No.
Perfect. Yeah, I love that. Any other advice for our preceptors, family physicians, anything else you want to share with us? You've come from this leadership position, you've done a lot of learning over your career. What have we not talked about?
Okay. So when people ask me about a teaching pearl, this is something that I learned from a rural preceptor years ago. And I think they're still in practice in southern Alberta community. But procedural skills. So that's often a situation where we are with our learner doing direct observation. I mean, whenever there's a potential for like, a procedure happening, we feel we need to be there, right? It's kind of the low-hanging fruit of like direct observation, being present and doing some teaching and the steps and that kind of thing. So this one colleague of ours had said, no, when you're doing a procedure or a learner's doing a procedure, perhaps for the first time, and we are, being good educators, we've rehearsed it all and this sort of thing. Say it's a mole removal, right? Scalpel in hand. Now they're in the room with you and they're doing the procedure. One of the things that makes everyone in the room feel uncomfortable is if something doesn't go as planned and the learner says oops or uh-oh or something like that. So we know that's not going to instill confidence in like the patient, or the whole room just feels a little bit more tense when that happens, right? Because it's a very vulnerable situation for patients to be into. So as part of the rehearsal, what that one colleague of ours had suggested was that you have a code word or like a code phrase. So the one that I had used with IUD insertions or endometrial biopsies was, Dr. Koppula, could you please check my angle? Just, no worrisome words, no urgency, just I'm looking for a double check. And that's just a code for us that we've agreed on beforehand that I need help, without saying, oops, I think I made a mistake, or uh-oh, I need help, right, in the room. So having that code word during a procedure or otherwise, like say, for example, if there's a conversation that's kind of going left, you can use that phrase if we're present, and then it's just I'll take over for a second, or reset something, or do a small self-correct, and then you can have the scalpel again, or you can go back to the IUD insertion. But the code words are a great tool that procedural skills wise, I really like.
That's so handy. I like that. So good.
You too.
Yeah, very good. Well, thank you so much for this engaging conversation and for your wisdom and for your years of service in this faculty development, because we've had a lot of lunches where Dr. Sudha has brought, some ideas for us to just kind of enrich our ability to help our learners and in our enjoyment of our clinical day. So it's a delight to bring you to everyone here as well.
And that's happened at some great restaurants in Edson too.
Yep. Perfect. Well, have a wonderful rest of your week, everybody. Thanks so much.
Bye, everyone.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.